to do. You have to consider the half-life. We found that the long-acting benzodiazepines that here at Fairview work better. They'll have fewer seizures and fewer DTs if we use that. There's a lower risk of breakthrough withdrawal when we use the Valium. They can be getting a lot down in 3A, and you send them up here, and it just gradually tapers. It takes weeks to get out of the system. If you do a drug screen 3 weeks later and you got a lot of Valium on 3A, you'll still be positive for Valium. You won't feel the Valium, but it's still in your system. It just goes down very, very slowly. There's a much lower risk of breakthrough withdrawal because the half-lives of the Valium are active. I mean, the metabolites of Valium are active, they're still working, and it's very long-acting. Sometimes if a person is older and they're frail, then we use Ativan because it goes in the body and out of the body quickly. And if you give a real older person too much Valium, they could be knocked out for a couple weeks because it takes so long to get out of the system. So the problems with the benzodiazepines are giving too much or giving too little. The benzodiazepines are an addicting drug. They're what's called reinforcing. People like the benzos. So when they get benzos for withdrawal, and then they start recovery, there might be a greater craving. There might be a greater risk of going back to drinking. Patients seek them. When you give it to them, they can get a little delirious. People that get all this Valium in ICU get a little loopy from it, but that's something we have to accept because it saves their lives. They also can be stumbling walk when you get a lot of benzos. You can get slurred speech, but I just tell patients it's a side effect. We're saving your life, just go ahead and take it. You may need to use a lot right away to prevent the withdrawal. Other medications we can use, clonidine. This is a little bit of an advancement in things in the Alcohol Withdrawal Update 2015. I've become more impressed with the using clonidine. It's an old blood pressure medicine. It's what we call an alpha-2 agonist. It blocks the release of norepinephrine. It slows down the catecholamine energy that's going on in the alcohol withdrawal. So it really works on the brain to stop all this high energy fire that's going on. Somebody said it keeps the excitatory spigot turned off. So it really blocks that. Clonidine is an alpha-2 agonist. Other ones are Precedex, Tinex, tizanidine, a muscle relaxant. But clonidine is the main one that's used for initial withdrawal. Clonidine can cause low blood pressure, but it's rarely a problem. All you have to do is get the person up and get them walking around, and the blood pressure will come up. Might cause sedation, and might cause the heart rate to slow down, but they might need fair doses. A normal dose of clonidine is 0.1 milligram, but 3 or 4 times a day. These people might need 0.3 milligrams 3 or 4 times a day. It's very different than the beta blockers. These alpha blockers work on the brain, whereas the beta blockers work on the peripheral nervous system. And so the beta blockers really mask the withdrawal. Alpha blockers treat the withdrawal. Some centers around the country actually just give everybody some clonidine when they check in. And they don't give it based on the blood pressure or pulse. They just give it to everybody. Clonidine can also reduce anxiety. And if somebody's got nausea and vomiting, clonidine can be just put under the tongue and it will be absorbed. And other medications, here's some notes on clonidine, alpha-2 agonist, sympatholytic, it blocks the release of norepinephrine. And those Precedex, Tenex, and Xanaflex are other medications like clonidine. The third medication is anticonvulsants. This is what we use for outpatient detox. It has some advantages in that they're not reinforcing, they're not addicting, there's no abuse liability. They have minimal effect on making you sedated. They may suppress kindling. They may help with post-acute withdrawal, so they've got that advantage too. There may be less relapse after using. So there's advantages to just trying to treat alcohol withdrawal with the anticonvulsants. There are several that have been used. Tegretol has been used. Several studies dating back to the 1970s have showed Tegretol to be as effective as the benzos. The dose of Tegretol is 200 milligrams 3 times a day. It reduces anxiety. It improves sleep. Gabapentin is the one that I use for outpatient detox. This has minimal side effects. There's minimal cognitive impairment, minimal abuse potential. Gabapentin potentiates GABA, so it affects that inhibitory system of the brain, and it blocks norepinephrine release, and it inhibits the excitatory glutamate. Gabapentin has been shown to reduce the scores similarly to the benzos. There's a reduction in the frequency of relapse compared to Ativan when you use gabapentin. The dose is 400 milligrams three times a day, and then you can taper it over a couple days. But I even keep it going for 10 to 14 days to treat the protracted withdrawal. And it's very helpful for post-detox anxiety. So gabapentin is a good medication to use. Depakote is another option. It's another anticonvulsant. There's fewer studies about Depakote, though. It might be helpful for those with a dual diagnosis, like bipolar disorder. So gabapentin potentiates GABA, reduces norepinephrine release, and inhibits glutamate. Phenobarbital, this has been reported to work just as good as the benzos. This is an old barbiturate medication. We use it for benzo withdrawal, which I'll talk about in another lecture. But it's very good for alcohol withdrawal too. We just don't need it as much. Phenobarbital can be considered when patients aren't responding to Valium. The dose is 130 milligrams every hour. You get persons visibly relaxed, and then you cut back. They might need up to a total of 700 milligrams. It's been found to reduce the delirium and the hallucinations. It's very long acting. Again, it will self-taper, so you can just get people better with it and then stop it. You don't have to taper it. The benzos, the Valium and Pembody and DTs, you keep giving it, and it seems to have a ceiling effect. It seems like all the benzo receptors are full, and more benzos aren't doing anything. With phenobarbital, the more you give, the more it works. If you give enough phenobarbital, you'll kill them. I mean, they'll stop breathing. So the phenobarbital won't have a ceiling effect, and so you can keep using it if you need to. If they still are in withdrawal, after getting about 1,000 milligrams of phenobarbital IV, you can go to the next step, and that's Precedex. Precedex is, like I said, another alpha-2 agonist. It's like clonidine, but it's 1,000 times as potent as clonidine. These people are used for only in the intensive care unit. It also blocks the release of norepinephrine. It's expensive, but doesn't matter. We're trying to save lives here. It reduces delirium and seizures. There's no respiratory depression. You can titrate it IV, and it helps opiate withdrawal if they're in opiate withdrawal too. So it can be a good medication. Sixth medication that can be used is propofol. This also is in ICU only. This time, propofol is the drug that killed Michael Jackson. It blocks the muscles from working. It puts people to sleep. They don't even breathe. So you have to put them on a ventilator. Propofol is an NMDA receptor antagonist. And remember, the NMDA and glutamate are excitatory, so it blocks that excitation. It's in the same class of drugs as ketamine, which is a horse tranquilizer. Very rapid acting. A lot of people, it stimulates GABA also, which is the inhibitory neurotransmitter. Does require a ventilator for sure. Ethanol. What about giving alcohol to an alcoholic in withdrawal? There's some centers around the country, mostly surgeons, that use alcohol. They give people alcohol for alcohol withdrawal. And a lot of times in my lecture, patients will ask about that. Can you just give alcohol? Well, you could, but the problem is alcohol is toxic in itself. It hurts the liver, as you know, hurts the brain. It doesn't work as well as Valium, and I think it's just dumb to use alcohol on an alcoholic, so we don't use that. Not as good as Valium, very toxic. The last one are the antipsychotics. These are like Haldol or Thorazine. They're commonly ordered but shouldn't be. They don't suppress the withdrawal. They don't stop the DTs. they're given, because people in alcohol withdrawal are delirious, they're crazy, they're acting wild. You want to give them a tranquilizer. So some people give them these. But they actually increase the chance of seizures and they can cause tremor. So I never use antipsychotics for alcohol withdrawal. And that's the end of the lecture. I thank you for your undivided attention, and now I can answer any questions you might have. Yes?
The gentleman you spoke of in the case study, do you still keep in contact with him? And if so, how is he doing?
That's 25 years ago, 30 years ago. He went back to New York. I had heard he did well. He was in recovery for a while, but I don't think I've had contact with him for over 20 years. I remember his nickname, but I don't remember. So I'm not sure how he's doing now.
Thank you.
Yes?
Do you have any other drugs that they're using off-label for withdrawal? Anything new coming up?
For alcohol withdrawal? The question is, are there any other drugs using off-label for alcohol withdrawal? I imagine there are by some centers. There's, some treatment centers are what's called alternative. They may use vitamin therapy or other things, but when you go to conferences that are within the medical establishment, American Society of Addiction Medicine, this is pretty much it. Yes?
Dr. Amer, thank you for coming in. I just wanted to ask you, what is the difference with the kidney and the withdrawal, let's say alcohol withdrawal versus the heroin withdrawal?
Yeah, that's a good question. Now, I think heroin too causes kindling. I think heroin withdrawal can change the brain. We do know with heroin withdrawal that the relapses, the craving is amazing. Whether that's just due to the effect of the heroin on the brain or the effect of the withdrawal on the brain, I don't know. But by kindling, we mean the withdrawal actually changes the brain, not that the alcohol changes the brain. So the question was about kindling and heroin withdrawal. Yes?
I know that Valiums are highly addictive, so like in the case presentation, if you was giving him 200 milligrams of Valiums, then do you have to detox them off the Valium?
Great question, but Valium is addictive. The question was about using Valium and then do you need to taper it? You don't, because Valium is so long acting that when you stop it, it's going to take weeks to get out of the system. It will just go down slowly all by itself. But it is addictive, and you're giving an addict something that's addictive. So that's why the recovery program, you can't just take somebody in detox, give them Valium, and send them home and tell them not to drink. They've got to have a good treatment. They've got to have a good recovery program. Yes?
Is alcohol the only chemical that can actually kill you from the withdrawal? Or can you die also from other withdrawals like heroin?
Yeah, great question. The question is alcohol withdrawal the only one that can kill you? Pretty much. It's the most dangerous. I've never seen any death due to withdrawal other than alcohol withdrawal. If somebody is on really high dosages of benzodiazepines, like Valium or Xanax, and they come off and it's not treated right, I would imagine they could get seizures and die. Heroin withdrawal, you're not going to die. You feel like you're going to die, but you're not going to die. So alcohol withdrawal, of all the chemicals and all the withdrawal, is the most dangerous. Yes?
After calling 911, obviously, what does a layman do if somebody's going into alcoholic seizures, withdrawal seizures?
Nothing.
Nothing?
Yeah.
Calling 911, do you hold them down? Do you let them?
Yeah, there's a lot of myths about that. There's a myth that the question is, how do you handle the seizure if you're there while 911 is on their way? There's a myth about sticking a stick in their mouth. It's too late. They've already bitten their tongue. They're not going to swallow their tongue. They're just going to bite their tongue. You might see blood coming out, but it's just going to be a little cut. You might see spit coming out, and that's where the expression foaming at the mouth comes from. You could turn their head to the side. If they're hanging over a ledge, get them back from the ledge. But otherwise, the seizure's going to go away in a minute or two anyway. And then they'll just lay it.
It's going to go away in a minute or two.
Yeah.
911's on
Yep.
the way.
Yep.
and
They'll be okay.
get out of the way.
Yeah.
Okay.
Yes.
Where would naltrexone come into play during the withdrawal process?
Good. The question is naltrexone during the process of alcohol withdrawal. Anybody coming in that's in alcohol withdrawal that's been on naltrexone, I stop it. Because I think naltrexone can actually make the withdrawal a little worse because naltrexone is the blocker. So I stopped the naltrexone and wouldn't start it again until they're in recovery. It's not helpful at all to treat alcohol withdrawal. Yes?
Yeah, I suffered seizures but never had ETs. And my question is, are seizures in and of themselves life-threatening, or do you have to cross into the DT?
Great. The question is, are seizures themselves life-threatening, or do you have to go into DTs? Seizures are not life-threatening. The only problem with the seizure is that the fall. When you fall and bang your head, fall and break your arm. But the seizures themselves aren't going to kill you, so nobody will die of a seizure. They're harmless. They actually, people do a little better after having had a seizure. DTs are the things that kill people. Yes?
What are the criteria for putting somebody into a medical coma with propofol?
Yeah, we just go down, the question is, what are the criteria for using propofol for medically induced coma? We would just go down the line. We would start with the Valium, and then we add clonidine, and then we go to the phenobarbital, and then we go to the Presidex, and then we go to the propofol at the last stage.
So they're still going through seizures, or if they're going through?
Still going through DTs, it's just not working. But that's rare. If we use these other things, needing propofol would be very, very rare, and that would be the intensive care unit. Yes? Either one.
We've got a couple gentlemen that had a fluid buildup in their stomachs. Is that end-stage liver failure, or are they about to die from that?
Question is, people that have fluid buildup in their stomach, that's from liver disease. Yeah, and no, they're not going to die. They just have bad liver disease. It depends on the individual. If it's just they stop drinking and it's treated, it can get completely better. Fluid is from the liver disease. It's not from alcohol withdrawal or anything. Yes?
I've noticed that county detox tend to use Benadryl. Is there any
Tend to use what?
Benadryl?
The question is county detoxing using Benadryl. I wasn't aware of that. That would be worthless. Yeah, Benadryl for alcohol withdrawal wouldn't do a thing. Make you a little sleepy, but in somebody in alcohol withdrawal, it's not going to do a darn thing. So that's a wasted medication. It's like using a fly swatter on an elephant. So yes.
I have one more question about the post-acute withdrawal.
Post-acute withdrawal.
What's the ceiling of how long that can actually last? And you said 80% of relapses can be attributed to that?
No, I said 80% of the relapses occur in the first 6 months.
Okay, that's a difference.
But how many of those are due to post-acute withdrawal? I would imagine a lot of them. And they say, 1 month, 2 months, 3 months, maybe 4. There's no cutoff, but it's around that time. So